move to our next speaker. Our next speaker is Dr. Milind Naik, sir. Sir heads the oculoplasty unit at LBPI Hyderabad. Over to you, sir. Sir will be speaking about the experiences in thyroid eye disease.
Hi, thank you, Gunjan. Am I audible?
Yes, sir, you are audible.
So at the outset, I would like to thank Gunjan, Namrata, AIOS for this wonderful session. We had a parallel session in OPAI going on, but I logged in here and I've been enjoying the talks as well as discussions, so forth. So my topic is about thyroid eye disease, our experience, and I'll just quickly take you through more of our research work back at LV Prasad. So when I was a resident before the year 2000, all I learned was proptosis, strabismus, eyelid anesthetics, the classic paradigm, although I was only examining patients. And back then, in 2003 and 4, this was pretty much the state of many of the thyroid patients that I would see in the clinic. They had significant complaints, but there wasn't much being done about them, at least in the ophthalmic community. For me, the real journey with thyroid eye disease began after my training with Bob Goldberg at UCLA. And since the time I have come back from the US, I really noticed that what we see back home and what I saw there as the so-called Western thyroid patient, there was a lot of difference. And I started to think whether our thyroid profile of patients is different because I used to see children less often and strabismus issues less often as compared to what I saw there. So I thought let's go deeper into this topic. And when I started to look at what data we already have, there was just one paper which talked about the prevalence of Graves in patients who have Graves disease, Graves ophthalmopathy in those who have Graves disease. And it just said that sight threatening was rare and the prevalence was pretty much close to 1/3. So thereafter, we decided to look at our entire spectrum of thyroid patients seen over a decade, which amounted to around figure of 1,000. And I'll just quickly go through this data, which was starkly different from what has been reported from elsewhere. So we looked at the female to male ratio and it was actually an inversion. So despite the fact that there could be some referral bias here, when I compared it to other papers, we noticed that as you come towards the east, this ratio does blunt out in its proportions. Age wasn't much of a drastic difference compared to the other papers, but we found that pediatric thyroid eye disease, as defined within 18 years, was less, and laterality was more. We have more of unilateral disease than the rest of the populations. Talking about the systemic condition, patients who present to us with the euthyroid state is much higher as compared to the other reported series, ours being close to 1/3. We also defined something which we noted as silent presenters. These are patients who lie within their first year of thyroid eye disease with normal serology, no antibodies, and no clinical activity score, but just classic findings of thyroid eye disease. When we looked at the presenting signs, obviously proptosis was more common, but what was surprising was that lower eyelid retraction scored slightly higher in its prevalence as compared to upper eyelid retraction. And then we also had ptosis and microbial keratitis, and I'll come to these in a while. So the summary of this demographic, this was not population based, but the demographic data from a hospital series suggested that our patient group was younger. There was a slight male preponderance, and 1/3 of patients are euthyroid and 1/3 are silent presenters. And we found that lower eyelid retraction was more common than upper eyelid. And ptosis was identified in 5.6% of patients who presented to us. And strabismus was quite rare. So the need to have these combined clinics between oculoplasty and strabismus isn't something which we found to be necessary. Quickly touching upon the microbial keratitis, here is an example of an active disease who was found to have C. pseudodiphtheriticum and S. pneumoniae, and we controlled this with cornea management as well as tarsorrhaphy. And we realize that tarsorrhaphy alone is often not enough in these patients. Sometimes you have to combine it with a levator recession, even in the active disease. And the severe ones, sometimes they just end up in an evisceration and a prosthesis. So that's the spectrum of organisms. Gram-negative was the most common. And we found that the associated risk factors to develop an ulcer included active disease, severe eyelid retraction, severe motility issues, and motility restriction, and male gender. Talking about upper eyelid, it is classically known to be the sign of thyroid eye disease, but when we looked at literature, most often it points out towards possibility of myasthenia. But when we looked at our data of 56 patients, we found that only 2 had thyroid eye disease suspected in their referral to us. And we found that lower eyelid retraction was very common in these patients. And etiology-wise, aponeurotic was more common cause than myasthenia, almost 2/3. And this often masked the upper eyelid retraction as a sign of thyroid eye disease. So just like how we have papers about simultaneous decompression and eyelid retraction correction, in these patients we have done simultaneous decompression and ptosis corrections. Another interesting paper by Dr. Rath from our Bhubaneswar campus, where he mentions about the dysthyroid optic neuropathy almost doubling if you have smoking or diabetes as the risk factors. Finally, coming to the point of lower eyelid entropion, this is something rare that we found in patients presenting with thyroid eye disease. We had a total of 5 patients, 8 eyelids, a younger population, and it could either be medial or a complete lower eyelid entropion, and thickened mid-lamella was the etiology found on VBM. And most of them which required surgical correction actually got corrected after the lower conjunctival incision for the floor and inferomedial decompression. So just a quick summary. Indian patients with thyroid eye disease have a different spectrum. They are more unilateral, milder, and silent presenters being very common. And eyelid signs such as lower eyelid retraction is more of an obvious finding in our spectrum. Thank you very much.